what we are doing in AIMS. When we had to sort of divide the spectrum of applications, we would sort of possibly divide it, we could possibly divide it into three kinds of applications. Ones that basically enhance your efficiency at doing what you do every day. So these are like preclinical managerial sort of tasks. And then there is the clinical decision support. So this is where the actual meat is.
Recording in progress.
Yeah, sorry. And then the new science discovery. So if we were to look at, we begin with efficiency enhancement. These are sort of the kind of images that we're all used to. We're used to these extremely crowded OPDs, the doctor-patient interaction, especially in these these government-owned healthcare systems, is possible only for minutes. We're used to seeing OPDs with 200 patients in 2 hours. And then for the patients, there are long waiting times. So how can we possibly leverage AI to really sort of solve some of these problems? These are two examples from what we're doing in AIMS Delhi. In one example, which is an ongoing study with Google, we're looking at how do we sort of leverage, make use of this time that the patient is waiting in the OPD. Can we make use of this waiting time, have a conversation with a patient, of a healthcare worker, and then this conversation can then sort of get converted, can be recorded, transcribed, translated, and get recorded into a patient summary so that the doctor is very quickly up to date on what the patient is actually saying. And can this enable, some form of the traditional form of EMRs? There's absolutely no way it can work in our healthcare system. So can we actually enable digitization also as a side effect of something like this? Another example where we're working with Care, where what we're looking at is we're again used to these scenes from emergency where there are 20 patients at a time who need immediate attention. It's an emergency after all, and there are a limited number of doctors who can cater to them. So can we start triaging patients and saying that among all of these patients, this one needs absolutely emergent attention and this one can be seen a little bit later? So all of these, basically, the safe deployment of these models actually need customization to hospital workflows. When you look at the problem, it looks like it's a very easy problem to solve if you think of the kind of models that we have today, which are available to all of us. But then, that's where the real world, the noisy real world comes in. These deployments happen in noisy rooms, not in the kind of quiet rooms where you can have these models, where these models are actually traditionally tested on. You need lightweight models. You can't have models running on massive computational resources at the scale that we're talking about. You need to leverage their ability to understand Indian languages. But even more importantly, when you come to medicine, and all of us practice medicine or have practiced medicine in India, we have to understand that a patient's expression of a symptom is very culturally grounded. The patient doesn't come to you and say, I have right upper quadrant pain. The patient is possibly going to say, मुझे घबराहट हो रही है, or something like that. So how do you really take it from that cultural expression on to trying to capture the reality of what their symptomatology is, to provide a summary which actually makes sense from a scientific point of view? We need to study patient acceptability, and we perhaps talk about this a lot lesser than we should, because is a patient who's coming to a hospital actually happy talking to an AI doctor? To what extent and to what parts of it is the patient okay with that? And we need to study whether it actually saves the patient's, the doctor's time, or is it actually adding somehow to the doctor's workflow? And of course, the traditional metrics of accuracy, completeness of transcription, the translation, summarization, etc. So from there, I think the efficiency enhancement actually forms one of the first areas of adoption for clinical care, because this is where it can truly make a difference to our workflow. Then coming to what really constitutes the meat of AI and health, and this is what we all tend to focus on more often than not. But speaking about clinical decision support systems, now there is the generation of AIs where there was narrow image-based models, and these have been mature for many years now. If you look at the first paper that came out on diabetic retinopathy, AI for diabetic retinopathy, that is nearly poorer. Um, in part because the equipment may be different, in part because the real world setting of data acquisition can be so different. And the clinical spectrum of cases, what do we need to use AI for? What is the disease predominance that we see over here tends to be very different from the West. But also, and more importantly, this is throughout the world, really understanding how this integrates into the existing system and whose time is it saving, whose work is it actually making better, is something that we are still figuring out. These are some examples that we're doing in AIMS where we've had these sort of this kind of tabletop fundus camera over which AI has been developed forever and ever. But when you look at the peripheral centers where you do actually need AI support for diagnosis of diabetic retinopathy, it's more often the handheld version that is used for capture of the fundus images. And this is something that we're doing with the Ministry of Health. This is called Madhunetra AI. It already has the MD12 CDESCO license and is being deployed across 10 states of the country. In another example where we looked at skin images in a project with the MOHFW, as well as in a different context with Google. When you look at skin images, it's very sort of plausible to do some of this diagnosis with the use of AI. However, most of the international AI systems are trained on Caucasian skin colors, and they just don't generalize to Indian skin tones. So, this is a project where we're trying to, and we have built out a series of models which actually work on Indian skin tones. Moving from the narrow image-based AI to what we used to in our everyday life today, even if we do a Google search, it gives you a host of, it actually gives you a summary of the sites and summary of what its understanding is. So these kind of large language models have actually seen tremendous growth in the last couple of years. And most areas of medicine actually lend themselves to transformation with language. Of course, all of your conversations, which can be recorded, they can be captured. The patient themselves interacting with AI systems to understand their disease process better, to get suggestions from them. But it also does extend all the way to recording of breath sounds, to recording of heart sounds, cough sounds, etc. And then all the way to surgical videos, though the surgical part of it is still in its infancy, partially, from a technical standpoint, also because of computational constraints associated with surgical AI. But again, speaking about the challenges there and work that needs to be done, we need to in a patient-facing scenario, we need to understand that the biggest challenge is how do you avoid hallucinations. We've all possibly, if we've used these language models enough, come across areas where it has very convincingly made up stories, with you. We have to understand the biases that they have, that they carry with them while they've been training, and we have to understand what is a safe deployment practice before we actually can use these at scale. Um, Surgical AI, like I said, is it needs real-time guidance and is computationally intensive, so still in its infancy. An example of this work is the AIM CDSS, as it's called. This is in deployment in the NHA. This is meant as a decision support tool for diabetologists in order to prescribe the optimum sort of medication depending on a patient's clinical status. Like I said, this is already in deployment in the NHA. Although this is a system which is developed over 15 years and uses traditional systems rather than the current day AI, and that's something which is work in the making. But the last, which I think, which at least in my view is one of the most exciting areas of AI in health, which is AI-led discovery. So can you actually use and leverage ML to actually understand disease processes and patterns itself? Because the ability of the ML to understand multidimensional data is so much more than that of a human mind. But if you need to leverage it for this, you need to be asking the right questions. You need to collect that kind of data and validate it. So I think this really opens up a world of possibilities. Going into drug development, a lot of big pharma actually use AI as we speak to actually discover new drugs, the protein folding patterns, the new drug discovery, and drug repurposing has undergone a tremendous change with the use of AI. And then coming to digital twins, so rather than actually doing an intervention on a real patient, can we actually do the intervention on a digital twin of the patient and see how the patient is likely to respond to a certain thing? To give you an example, in case of breast cancer, we said we do know that there is an increasing incidence of breast cancer over the last decade or so in India. And we know that this increases more in urban cohorts than in rural cohorts. So, can we actually find out why this is happening? And we went ahead and asked, a ton of questions. We actually asked, the questionnaire had some 80 questions to patients in rural and urban cohorts. And this consisted of anecdotal questions like, are you vegetarian or non-vegetarian? And do you use a deodorant? And on the other hand, also had questions like, do you have a family history of breast cancer, which are known risk factors. And we have an initial model that's built out of this, where we're trying to predict an individual's risk of developing breast cancer. And this is something that is in clinical trial at the moment. Similarly, not just repurposing of drugs, but can you actually repurpose maybe imaging equipment? So we know that mammography and X-ray actually come from very similar equipment. It's actually built out of an X-ray equipment. So with certain differences such as the detector resolution, the source to image distance, the amount of energy that comes out of the tube, etc. So can we use AI to actually generate a mammogram from the X-ray rather than actually doing it necessarily on a special equipment? So these are examples of how we can possibly, it opens up an arena to really think out of the box and come up with solutions that really don't exist or are not possible in today's day. In terms of in terms of really giving access to people, and in terms of ecosystem building, this is some work that we've been doing on trying to release data. So we're trying to make data available to people, as many people as possible, to really access, download, and do your work on. So this is on the MIDAS database, which is from ICMR and IIC, as well as on the IBIA, which is the DBT database. So essentially, I mean, when you look at AI in health in general, it can find application at multiple different levels, starting from a patient level all the way to a health system level, if you have the right kind of data. And yet, you would think that AI in health really is a solved clinical problem. So let me challenge that a little bit by saying, by talking to you a little bit about why is AI in health challenging. And for this, I'll begin with an example, not really from healthcare, but from Amazon. So, back in 2014 is when Amazon said, we spend a ton of time and effort in trying to sort of look at whom to recruit and whom not to. And we have tons of data on this. So why not build out something which will help us actually choose the right person? What they actually ended up finding is that in this whole male dominated tech world, they found that their AI model was somehow biased against women. And that's because, of course, one pattern that the AI found in its data is that being male is a very favorable thing for being in the tech industry. So it started penalizing people if their CVs actually said that they were women. They tried correcting the tool, but AI found very innovative ways of actually finding out, and it penalized things like, she was the captain of the women's soccer team, etc. And the key takeaway from this is essentially the data quality matters a lot. What you're training on matters, and there are sometimes invisible biases that you may not have even thought of. Of course, people who built the AI would not have even thought that to the model, gender might become a factor that might affect its decision making. Secondly, human oversight is absolutely critical. They wouldn't have discovered this unless they were actually following up on what really was happening. And then there are ethical challenges in AI that all of us need to sit down and talk about. Coming to, taking this from the Amazon training example into a real world actual clinical example. Now, this is one of our first experiments. When I started about 10 years back, this was the first experiment we did. We said, let's build a model for pneumonia detection on chest x-ray. And this is healthcare AI 101. This is probably, what everybody starts off with. We got very good accuracy when we looked at our training data. Our training data was from the RSNA Kaggle database, and then we found, for the pneumonia cases, and found another database. Chest X-ray has a lot of public data that is available for researchers to actually start their work on. But then when we actually saw how it functioned on Ames data, we found that it actually functioned very poorly. And when we tried looking into why that was happening, we did something called a visualization where you try to see where is the model looking when it tries to make a particular decision. And we found that it was actually looking at the lines and tubes. So it used to focus on the endotracheal tube or the ICD. Data set. So it learned to predict pneumonia wherever the patient had a line or tube associated with it. So it made the correct sort of decision, but it made it for all the wrong reasons. And we sort of realized this when we tested it on patients who walked in and suddenly it wasn't able to catch the pneumonia. So just a very important takeaway point that data set biases may be very subtle. It may not be something that you're actively thinking of as a human being. As a human being, it would be impossible to think that you could detect pneumonia with these lines and tubes. This somehow was completely hidden to a hidden side. So, which is why we have to be very, very careful when we deploy these models, and be wary of the kind of biases that might enter our training and testing data. Now, this is a video again from the general world in general of the autonomous driving vehicle, where this cyclist was actually reasonably well seen. These kind of images existed in the training and the test data, and yet in this particular instance, the cyclist got completely missed, and this was a fatal accident. So, the question really, and it's only a question for all of us to think of, I don't have an answer to it, is in an area where it involves patient lives, is the reasoning behind the AI about as important as the result of AI? And the reason I say this is often you would see that autonomous driving cars are actually very safe. They're actually perhaps more safer than human-driven cars, and yet for a patient who actually lost their life, not a patient, but a person who lost their life because of an autonomous driving car, is the why an important question to answer? And I'll give you the flip side of this. What is the ethics of not using AI if your statistics actually tell you otherwise? For instance, all of us prescribe paracetamol. All of us have had paracetamol to pull down our fevers, and yet how many of us really know why it is working the way it is? So if a model can consistently get an answer which is useful clinically, are we correct in not using it because we don't understand what's going on behind it? So again, just food for thought for all of us to really think of. These are some of the issues which are really facing the whole field of AI today. Now, some examples from around us, the NCD portal. Now, this is not really AI, but a step towards digital health. When the NCD portal really came up, and healthcare workers were asked to sort of fill in the details on the portal, one would have imagined that it would make their life so much easier because you don't have to carry these papers, you don't have to keep repeating what you've already written on one piece of paper in order to duplicate it. Here is a portal which is perfectly made for you. It will cut down your time if you started using it. And yet, the adoption was really, far from what you would expect it to be. And what they found actually is that instead of real world adoption, the healthcare workers continued to write on those pieces of paper, But then they had to employ data entry operators who would then copy what was written on that piece of paper into the portal, defeating the entire purpose that it was actually made for. Another example, there are a ton of apps which actually promise to be Asha worker apps, most of them AI driven. But to give you two examples from, you know, colleagues and stories that they have faced while actually trying to deploy it. One from Gujarat, where Anganwadi workers were given this app for noting down pregnancies. They suddenly found that the number of high risk pregnancies that were being noted on the app decreased dramatically. Most of the high risk pregnancies would actually find their way to registers, whereas the 80% mark of noting down pregnancies into the app was met by putting in all the normal pregnancies into the app. And when they went and spoke to the Anganwadi workers, they simply said that, look, it gives you too many alerts and disturbs you too much while even talking to other participants, that it was really not feasible to use the app. Another example from Karnataka on an Asha worker app. This was an app that had a conversational agent along with the person, with the Asha worker, where the conversation, where in conversation the app could actually guide the worker on what is to be done, and it found almost no adoption. And the reason for that was when they spoke to Asha workers, they found out that an Asha worker had a certain standing in a community because people would respect her for the knowledge she brings. And suddenly there was this app that was talking to her and telling her what she's supposed to do. And people stopped giving the Asha worker the importance that they used to. So, really, the importance over there. An example from not really AI, this was a previous generation of AI, which was actually hand engineered features. So, firstly, this is not really what we call AI in today's day. But if you look at the date on this article, 1998 was when computer aided diagnosis, which was a way of actually marking out a cancer on a mammogram, actually came into being in mammography for the first time. And look at what this paper says back in 1998. It says that the CAD system has the potential to become a second reader, and further developments are expected to improve the accuracy of detection of masses. Now, let's cut down to this article, which is about 10 years after that one. This is in the NEJM in 2007, and it's entitled Influence of CAD on the Performance of Screening Mammography. And I'm going to read out the conclusion for you. Excuse me. It says the use of CAD is associated with a reduced accuracy of interpretation of screening mammograms. The increased rate of biopsy with the use of CAD is not clearly associated with improved detection of invasive breast cancer. Now, 10 years apart, they're saying diametrically the opposite set of things. And imagine the influence it must have had on the spending on the healthcare system during this decade. While what we use today is not CAD in the form that it was used back then. And there have been improvements, leaps and bounds since back then. The reason I brought it up here is really the necessity of well designed clinical studies to prove whatever it is that we want to. And the onus for that lies on us squarely. So, just to reach out, since there are a lot of MBBS students actually watching this, just wanted to reach out to say that very important to not create hype, not publish for the sake of publishing, not publish for the sake of getting something on your CV. But when you do real work, genuine work, you are able to actually make a true difference on ground. And that's what we should aim for. The responsibility for a well designed clinical study to evaluate something scientifically and then giving a message which is appropriate to what your scientific study actually told you about is very essential to avoid things like this. So, I'll show you one example from my own thesis. um, my PhD thesis. This was me just being lazy. I wanted to make a slide and show what piecewise linear transformation did on my images. And I, sort of went to an LLM and said, look, I need to draw a graph of piecewise linear transformation, and these are the three segments. This is what I need on the x-axis, y-axis, etc. And it gives me this graph. Now, I'm actually not, I'm actually trained primarily to be a doctor. And then much later, I did data science in my PhD. So I was a little confused because this didn't quite look right to me. So I went ahead and said, okay, why are these two segments so horizontal? Shouldn't they be a bit more vertical? And look what it says. It says, yes, you're absolutely right. In piecewise linear transformation, they should not be horizontal. They should be slightly vertical. And it gives me the fresh new graph. Now imagine if I did not